Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. It's a great delight for me to inaugurate this year's session. My name is Eric Lim, and this is Premier Education brought to you at no cost, thanks to our really loyal sponsors, AstraZeneca, Medtronic, and Medela. To kick off our season, we have Dr. James Black here today to talk about advances in next generation liquid biopsies in thoracic oncology. James, over to you.
Thank you very much indeed, Eric. So yeah, great to be here, folks. And yeah, going to be talking to you about some work that we wrapped up about 6 months ago in my postdoc at the Francis Crick Institute in the lab of Professor Charles Swanton, looking at liquid biopsies for lung cancer. So when we talk about liquid biopsies, we're talking about the study of circulating tumor DNA. So circulating tumor DNA is DNA that's been shed from cells, cancer cells, that then leaks into the bloodstream somehow and it sort of is admixed with the normal cell-free DNA and can be detected using any of the unique features about cancer DNA, such as point mutations or changes to methylation. And in the context of lung cancer, there are multiple use cases in terms of using this as a biomarker for high risk early stage disease. So you can imagine pre-detection. It could be used to identify patients who might have cancer. It could be used along with TNM staging, the so-called TNMB, B being blood, to better stratify patients at the time of diagnosis. Or it could be used in conjunction with neoadjuvant treatment, and also prior to adjuvant treatment to stratify patients and tailor treatment accordingly. Now, all of these are sort of somewhat theoretical and being studied in terms of how effective they are. Now, in terms of detecting circulating tumor DNA, so this is a great challenge because, as I mentioned, within the bloodstream, you've got a lot of cell-free DNA that's just shed by normal cells into the bloodstream. And so tumor DNA typically is a very small fraction of that, but detecting it is very predictive for bad outcomes. So a lot of work has gone in through academic laboratories and in industry in terms of optimizing approaches to detect circulating tumor DNA. And so there's basically been two broad schools of thought. One is so-called tumor agnostic assays, and the other are so-called tumor informed assays. The tumor agnostic assays very attractive because they don't need you don't need to inform this assay with details from a biopsy. You could just test a patient out of the blue, and if you identified ctDNA there, you'd know it existed. These are less sensitive, so they have a limit of detection, which is basically the proportion of this is the limit of detection is the ctDNA level at which you can be confident 95% of the time you'd be able to identify ctDNA were it there in that patient. And so they have a limit of detection typically in sort of 3 or 4 figures parts per million. And then there are these tumor-informed assays. The sort of first generation assays have a limited detection around 80 to 100 parts per million, but there are some new assays coming online that can detect ctDNA down to single figure parts per million. And so what we were asking is, how much better is the clinical performance of ctDNA in terms of informing patient outcomes if you use one of these ultra sensitive assays? And so we undertook this question in the TRACER-X study of lung cancer. So that stands for Tracking Cancer Evolution Through Therapy. It's a multi-site study across the UK, including recruitment at the Royal Brompton, of course, where basically patients with early stage disease undergo surgical resection, their tumors are excised, sequenced in multiple regions, and then ultra deep exome sequencing done on those regions, and then blood profiled, and germline blood, RNA-seq, a whole host of different things. These patients then followed up through the disease course, and very often we're able to get a biopsy of the metastatic sample when, if and when patients unfortunately relapse. And there's been a lot of insights into the study of ctDNA so far through TRACER-X. But what we've seen is challenges with respect to the sensitivity of the assays. So we've seen that the signal is somewhat muddied by the inability to kind of crisply define which patients are ctDNA positive and negative down to really low sensitivities. And so these are some of the indications, thinking about in patients with lung adenocarcinoma, preoperatively saying, do they have ctDNA, yes or no? And that being prognostic. This so-called landmark time point, which describes the post-surgical time point of evaluating whether surgery was able to remove ctDNA from people's blood, and then thinking about monitoring during treatment, so adjuvant therapy or even in later stage disease. And so all of these time points require a really crisp, high sensitivity assay that's able to exactly divine which patients have or do not have ctDNA. And so we teamed up with a company in the States called Personalis. Now they produce a very high sensitivity assay indeed. So they track about 1,800 personalized mutations per patient. So you'll take a patient, they'll sequence the tumor, they'll do whole genome sequencing, and then they'll make specific panels for each patient that can then be run and rerun through the disease course. And so this is a paper we published from Personalis. We published this in Nature Medicine last year. And this basically, this top figure is a mock-up from the Abosh et al. Paper in Nature 2023, where they've used a 200 variant personalized assay. And what you can see is that this is a preoperative time point. So this is saying at diagnosis, do you have ctDNA, yes or no, in patients with lung adenocarcinoma? And you can see a really nice split between those who are ctDNA positive and ctDNA negative in terms of their prognosis. But what you can also see is that among the ctDNA negative patients, this is very much this isn't a definitive signal that they're going to be disease-free. And so when you look at what happens when we use the ultra-sensitive assay, you can see that in lung adenocarcinoma patients, being ctDNA negative now with this much more sensitive assay is an extremely clear signal of good prognosis. And what we further see is that the level of ctDNA that we detect when we do detect it is also prognostic. So you can see a difference between weakly positive patients. This is again preoperatively adenocarcinoma, weakly positive, where ctDNA is detected but at a low level, and strongly positive, where it's detected at a high level. You can see a difference emerging there. So this is baseline time point adenocarcinoma, but we're seeing a really clear signal for the benefit of using one of these assays. So that's obviously thinking about one static time point preoperatively. What we've also got in TracerX, because we've got this mammoth set of patients with loads of follow-up data, we're basically able to follow these patients up through the disease course, and we've very often tracked, we've sort of managed to collect blood through the disease course as well. So here you can imagine some different patients, and I'll just show you the types of data we have before I get stuck into some of the results. So this would be a preoperative time point. All of these patients with a black dot indicating that ctDNA was detected at that time point. These are all real patients. Now going into this so-called landmark time point, which is this time point between 10 and 120 days post-operatively. So this is the first post-operative time point, and we can use this to say, or we could theoretically use this to say, was surgery successful in ameliorating these patients' ctDNA levels? You can also see some patients, some high-risk patients getting adjuvant therapy here. So the top patient has managed to clear ctDNA, the second patient has not managed to. The third patient has had another pre-adjuvant time point and has then received adjuvant therapy. And then these patients have followed up. So you can see the top patient surgery has basically cleared ctDNA in this patient, and they've had a very, very long and durable period of being ctDNA free. The second patient, surgery didn't work essentially, and then they've undergone a relapse in an extrathoracic site after about 4 years. And then this third patient had adjuvant therapy. It wasn't successful. They've had intrathoracic relapse after a year, and they've unfortunately died after 3 years. And so we've got this data for 433 patients from the TracerX cohort, about 3,000 time points we've sampled. We've got ctDNA levels, and we've got a load of clinical information, adenocarcinomas, squamous cell carcinomas, and then some other types. And for the purposes of this, we've kind of grouped them all as non-adenocarcinomas because they tend to behave quite similarly in terms of their ctDNA shedding, whereas the adenos are somewhat different. And so we've got this massive amount of data, and just eyeballing this plot, which is basically all you can do because there's so much data, it's essentially uninterpretable. You can see if we've split the relapse patients and the non-relapse patients out. And what I hope you can see is that in terms of the dots, you're getting far more black dots indicating ctDNA positivity in the relapsed group on both the adenos and the non-adenos than the non-relapse group, where there are more of these white dots or the indicating ctDNA negative. And having said that, there are a few exceptions of patients who don't relapse who are ctDNA positive, and then there are some patients who do relapse who are ctDNA negative. So some interesting things to dig into, but broad patterns emerging. So thinking about the cohort, we've got 433 early stage patients. About 40% of them received adjuvant treatment. This was before the days of neoadjuvant treatment. ctDNA detection across a broad range, median of over 5 years of follow-up. So I'm just going to take you through some of the results. Probably don't have time to go through everything. This is work we published at the end of last year in Cell. And so I mentioned this post-operative landmark time point. So this is clinically really attractive because you could basically say we've done our surgery, we had a ctDNA assessment preoperatively. We're then going to take an early post-operative time point and get a feel for how how that might be used in prognosticating for these patients. And so you can see some data here thinking about basically whether patients will relapse according to whether ctDNA was detected. And what you can see is that the sensitivity for detecting clinical relapse with ctDNA at this time point is about 61%, with a median of 250 days of lead time over standard of care imaging. So that means that typically we're detecting the presence of ctDNA in relapsing patients 250 days before they would typically present. So obviously a theoretical window emerging there where you could intervene. And 42% of these detections are occurring at this what we're calling the ultra-sensitive range below 80 parts per million, which were the limited detections of these first generation assays. And so here you can see the adenos and the non-adenos, the early post-operative time point, and you can see quite a few instances where basically patients don't relapse, but there is ctDNA detected at this time point. You could ask what's going on here, and what we see actually is there's an enrichment for patients who ultimately go on to clear ctDNA using adjuvant therapy. So this time point would have been taken prior to adjuvant therapy, then given adjuvant chemo, and so these dark blue dots are basically evidence of the sort of small but very real fraction of patients who experience basically cure due to post-operative adjuvant chemotherapy. So I mentioned the ultra-sensitive landmark detection, and so we can think about how useful this ultra-sensitive detection is at this landmark time point, this post-operative window between 10 and 120 days post-operatively. And you can see that just detecting it or not detecting it is able to split very nicely these patients. But then when we superimpose the level at which ctDNA is detected, we get a further split. So you can see the use case here for the ultra-sensitive assays, splitting ctDNA not detected at landmark, detected but at a low level, so less than 80 parts per million. And if it's detected at a high level, these patients have a very poor prognosis indeed. They're basically de facto disseminated disease. But what's quite interesting is you can actually use with this ultra sensitive approach, you can use the kinetics of ctDNA to predict response to adjuvant treatment. So this is the subset of TRACERx patients where we were able to get a post-operative pre-adjuvant time point and a post-adjuvant time point. And so we can use these to say which of these patients, all of whom had ctDNA still present post-operatively, so surgery had not cured them. They all then received adjuvant therapy, and they had another ctDNA time point after adjuvant therapy. And you can split those that cleared or did not clear ctDNA. So on the left, we've got patients that did not clear ctDNA during adjuvant therapy, and basically 100% of those patients go on to relapse. However, if ctDNA was cleared, which happened for this group of patients, about 10 patients, only 50% of these relapse. So this is suggesting an early signal where ctDNA kinetics, the clearance of ctDNA during adjuvant treatment, can predict durable clinical response. And what's quite interesting is thinking about the level at which ctDNA is detected. So here I've got relapse-free survival on the left and overall survival on the right. And I'm splitting patients out by this post-surgical pre-adjuvant time point. These patients all undergoing adjuvant therapy subsequently. Now, the best outcomes are in patients who, and these are all patients who pre-operatively did have ctDNA. The best outcomes are in patients where ctDNA wasn't detected pre-adjuvant therapy. They then receive adjuvant therapy, tend to do pretty well. But you can see a split between this gray group and pink group in terms of overall survival and RFS, and that this is significant in both instances where the level at which ctDNA is detected is prognostic through adjuvant treatment. And so you can see those where surgery managed to get the ctDNA level down to below 80 parts per million. These patients typically benefit from adjuvant chemo very well, compared to where it wasn't able to get those patients down to less than 80 parts per million. Again, these patients doing quite poorly. And then in terms of the what's actually happening here and whether that's predicting clinical outcome, it does seem that the actual clearance of ctDNA itself is predictive for a good clinical outcome. Again, sorry, I've switched them around here. Overall survival on the left, relapse-free survival on the right. Clearing ctDNA during adjuvant therapy seeming to be a correlated with a positive prognosis. And then an interesting kind of anecdotal piece of data. This is looking at the number of cycles patients underwent. Basically, all 10 of the patients who cleared adjuvant therapy, having been ctDNA positive post-operatively, had completed all 4 of their adjuvant cycles. And those that completed 1 to 3 cycles, of which there were 9 patients, all of them ultimately did not clear ctDNA. And so you can use this to kind of build risk models for evaluating the chance that a patient will remain relapse free. So this could be quite useful in terms of kind of telling patients sort of risk, how likely are they to relapse after a certain time point. So here you can imagine a patient that comes in, let's say we use 1 month as an example, they're ctDNA negative 1 month after surgery. The chance that they'll be relapse free by 5 years is 85%. So that's quite an interesting, useful piece of information to maybe tell patients. Obviously, this sort of stuff needs validating in larger cohorts, prospectively, etc. Or after, if they're ctDNA negative after 1 year, 90% of being relapse free after 5 years. And so you could imagine this kind of emerging model of how you might use ctDNA to guide lung cancer management. So you could split patients up into more kind of defined groups. You could imagine those patients that are negative ctDNA preoperatively, they could be quite low risk, perhaps de-escalating to a sort of annual intrathoracic radiographic surveillance, etc. And then if you're positive preoperatively, you could kind of split on the basis of detection at this landmark time point. If it's negative, again, you could sort of have you could have slightly de-escalated surveillance. You could sort of consider adjuvant therapy. I think there's some interesting trials underway where this kind of information is used to guide patients' entry into adjuvant therapy trials. And then you can basically imagine kind of strong landmark positive patients being treated as sort of de facto disseminated disease. And again, I think, trials for these patients, thinking about giving kind of late stage therapy for these patients, be very interesting to see what happens there. So yeah, key takeaways. So we saw that much better detection rates in adenocarcinoma were demonstrated with this ultrasensitive assay. We saw that lots of the post-operative detections occurring in this ultrasensitive range, so highlighting that this type of assay is really necessary to kind of crisply stratify patients. This opens the door to like ctDNA guided adjuvant therapy decisions. Clearance on adjuvant therapy itself seems to be an indicator of benefit, and overall, using ctDNA testing in non-small cell lung cancer has the potential to essentially be able to guide management at all phases of the clinical disease course. So that's basically everything I had to show, and I'd be delighted to take some questions.
Excellent. Thank you so much, James. Amazing amount of work that you've done. Congratulations to you and your team as well. For those some primer questions to start with, if that's okay. When you say circulating tumor DNA, can you tell us a little bit about how you identify between tumor DNA versus germline DNA from white cells and so on and so forth?
Yeah, so tumor DNA differs in a number of key ways, and these are sort of used differently by different approaches to detect ctDNA. So the approach that Personalis use is they recognize that tumor DNA typically have a lot of mutations. So these are basically typically smoking-induced mutations that aggregate over the years prior to diagnosis, and they will basically sequence the tumor. They'll biopsy the tumor, sequence it, and then build a personalized panel of these mutations, which will then be tracked during the disease course, so they can be used to identify. There's another very popular approach with companies like Grail, where they're looking at differential methylation patterns, which are also pretty specific for tumor DNA, turn out to be methylated in sort of completely different ways to the germline. You can also use things like copy number variation. That tumor cells are messed up in all sorts of ways that are really unique to tumor cells typically.
Thank you. A question from Elaine Tay, who's asking, does the tumor volume in terms of tumor size and nodes affect the level of circulating tumor DNA?
Yes, it does. Absolutely, yeah. So yeah, that definitely correlates. It's not the whole story. There are a lot of different factors about each tumor that influence the degree to which it sheds. So we've looked at stuff like you can look at the RNA-seq and you can look at how quickly the tumors are dividing. Things like Ki-67 relates to ctDNA level, but absolutely tumor volume does correlate. But as you can also look within individual TNM stages, and you still see a kind of really crisp stratification between positive and negative patients. So that does relate to it, but it's not the whole story.
You've already highlighted so many potentials for clinical use. When do you think it's going to be ready for prime time for us clinicians to use on a routine basis?
So I just sort of don't really understand why we're not using this all the time, because I think you could probably, on the basis of this, I think you could probably use it in the clinic already in some cases. I think the issue is cost. So I don't actually have up-to-date figures on how much this would cost, but you essentially have to do whole genome sequencing of the biopsy. You then have to build a bespoke panel, and then you have to use that panel on some subsequent time points with ultra deep sequencing. So it's quite a lot of sequencing needs to be done. I think the main issue is the sort of logistics. So if you're thinking about that preoperative biopsy, that has to go to let's say America, has to be shipped back. You want a really crisp turnaround to be able to get decisions to be made in the time window. So I think there's some issues to be smoothed out there. But ultimately, I think in terms of the data, to me, it just seems an absolute no-brainer to sort of be integrating this. And I think there are some, in the UK, there are definitely some leading clinicians who are doing this for other indications.
Yeah, quite a few people asking about cost as well. Dr. Therese and Dr. Patel asking about, do you have a rough idea on or a range of costs?
Yeah, so I think my understanding, and I'm probably going to misspeak here, which is terrible because I'm being recorded. I think I remember. I think their aim was to get it down to $2,000 an assay, was my understanding. This is probably a bit out of date. It's probably at least a year out of date. I don't know how they've progressed on that. Obviously when you look at the cost of actually doing the sequencing, it's completely pennies. But obviously building the assays, doing the shipping, etc., is probably what kind of creeps up. But so I think it's about $2,000 an assay. But if you think about the getting a patient and kind of clearly identifying them as someone who can be free from surveillance, free from adjuvant therapy, you're saving huge amounts of money there. And so I think if we did manage to develop a system where this was sort of smoothly integrated, I think it could be incredibly cost saving down the line.
Question from Dr. Al Sherry, who's asking for patients immediately post-op with high levels, more than say 80 parts per million for DNA. How many of them, what proportion normally is cleared with post-op adjuvant chemotherapy?
Yeah, so we found so these are quite small numbers because yeah, essentially the fraction of our cohort that was ctDNA positive post-operatively then had all the correct time points, the blood collected at all the right time points, and then we were able to measure it immediately following adjuvant therapy. There weren't that many patients that fell into that category, so it was small numbers. But the signal that we were seeing was that being ctDNA high, so above 80 parts per million post-operatively, those patients derive very little benefit from adjuvant chemo, it would seem. The patients where they did seem to derive benefit were focused on the sort of lower post-operative ctDNA levels. So yeah, we if it was if it was me sort of designing a trial, I think what would be really interesting is for that group where you're essentially you've got high ctDNA levels in spite of surgery. I would think it would be really interesting to treat those patients basically as disseminated disease stage 4 and do a trial to see if giving late stage whatever it may be immunotherapy etc was able to sort of benefit those patients.
Thank you. Got a question from the previous chair, the TNM Staging Committee, Professor Ramon Remy Porter, which I'll probably answer with you. It'll be unfair to ask you to answer this. Do you think ctDNA could be integrated as part of the TNM classification? So I'm part of the TNM International Committee as well, and we are currently working on this to evaluate circulating tumor DNA as a potential biomarker, probably as an additional prognostic factor rather than putting it into the M category. But here's the catch. The data that's being collected across the IASLC and across the world are principally only on mutations for which there's drug treatment for. So currently, we've got lots of information on EGFR, we've got information on ALK translocations, KRAS, where there's potential treatment.
Yeah.
Now, the human genome is 1 terabyte, and it's interesting or fascinating how clinicians are looking at a handful of genes, or they're really enthusiastic, 160 genes. But 1 terabyte of information is huge. And from your idea of scale, James, do you think that incorporating circulating tumor DNA into a staging system is ever going to happen will it happen in the next 5 years? Because every system looks at a different profile. Everyone classifies circulating tumor DNA differently. And we actually don't look, we only look at such a small fraction of the actual, complete amount of circulating tumor DNA. What's your view on this?
Yeah, it's a super interesting question. So I think in answer to the original question for the audience, I'm a big fan of the idea of this TNMB staging, so T tumor no metastasis blood. Um, and I think it could be really useful. Your point, Eric, is completely correct. What happens right now is you've got this hodgepodge of assays, some people using it just to look for an EGFR mutation, and it's completely heterogeneous. It's not really appropriate for kind of a standardized, you couldn't here we're tracking 1,800 mutations, right? This is not the same as looking for a T790M mutation and saying, am I detecting it? Yes or no? Like they're just not comparable in any way, shape, or form. Eric's point is extremely well taken. This is just a completely different order in terms of data storage, in terms of compute processing capacity required to deliver a downstream decision. The only thing I'd say is what a lot of these companies are doing is they're essentially trying to do all that work for us. So they're not saying, we'll do the lab work, you guys need to figure out the bioinformatics. They're sort of marketing themselves as an end-to-end solution for clinicians. Now, I'm not paid by Personalis. I have like no skin in the game at all. If it was me, I would want, all the data across all the different cancer types is basically saying it's really important to get a really sensitive assessment of whether there's tumor DNA in these patients, yes or no. I probably wouldn't be using like the sort of is there a KRAS G12C? Is there any GFR? I probably wouldn't be using that to guide treatment. I would want to use, I would probably want to use assays that are this sensitive to be doing those assessments. Now that clearly there'll be all sorts of difficult things to sort of figure out in terms of cost, in terms of logistics, but I just think the data is so strong in terms of how we're seeing patients separate by this basically this single metric that it's clearly going to be worth it. And those systems where they can adapt and they can integrate these types of approaches are going to just do better.
Excellent. Thank you so much, James. There's always just too many questions and not enough
Yeah.
time to answer. You gave a fantastic talk today. Next week we won't have a session because it's the STS meeting in the USA, and we'll come back the week after with Dr. Anand Patel talking to us about smoking cessation. So once again, thank you to our sponsors, AstraZeneca, Medtronic, and Medela, and especially to you, James, for coming back to speak to us about your excellent work that you've done at the CRIC. Thank you so much.
Thank you very much, Eric. Cheers all.
Bye bye.